Health Committee meeting to order at 12:34. Let's go to the Lord in prayer here. Father, thank you for today. Thank you for the responsibilities that we have as a health committee to serve our people. We know that our citizens' health is vital, and we certainly praise the abilities that we've had to hire individuals, physicians, all those that provide for our people. We're thankful for the ability to do that. May we always continue to be the best stewards of our resources that we can. Thank you for this time you've delegated to us. In Jesus' name, amen. Roll call, Shelley.
Yes, sir. Mike Dobbins.
Here.
Dora Petz-Count. Sean Crittenden. Here. Joe Deere. Aye. Rex Jordan. Here. Johnny Kidwell. Here. Darrell Legg. Here. Wes Nofire. Aye. Joshua Sam. Here. Mike Shambaugh. Here. Melvina Shot Pouch. Aye. E.O. Smith. Here. Condessa Teehee. Aye. Victoria Vasquez. We have a quorum. Thank you, Shelley. I assume you've had time. All those in favor? Aye. Motion passes. Time for reports. Mr. George Vallier. Welcome, George.
Good afternoon. I think you have my report in your packet. At least I hope you do. In addition to that, the American College of Gynecologists and Obstetricians, they showed up at the first thing this morning, and we're getting our yearly or two-year survey from them. They're going through the labor and delivery and women's health. We've always done well on that survey, so they're there this morning. We added, if any of you have been by the hospital and have seen our drive-through out front that we do drive-through testing we set up when COVID first started, we have insulated and added air conditioning and heating to it for the staff that work out there so that they don't literally cook in the summertime and freeze in the winter. So the drive-through portion, the entire structure now is insulated and heated and cooled. So that took a little bit of doing, but we finally got it done. We continue to work on get the groundwork done, or the scope of work ready for that. We are purchasing two mobile buildings, one to put out back and one to put up front. One is a training area out, a large training facility out back, and then the other one will be for patient care up front, right there by the pediatric department. We continue to give shots in the vaccinations down in the same vaccine room we've had since COVID started. We continue to do that, and first and second vaccinations and boosters. With that, are there any questions?
Questions for George. Mr. Deere.
Hey, Valerie, how are you?
Good.
I got a list of questions pertaining to the Claremore Hospital, obviously. So I want to read them off and just have you answer if you can. The first one, for the past 5 years, how much has Cherokee Nation contributed to the Claremore Services Unit as shares for inpatient and outpatient purchase and referred care, like contract care?
I don't have that number. That would come from Lindsay King at area office.
Okay. And you can give me her number or email it to me.
Okay.
Second one, how are we able to discern for the past 5 years' budgets how much of the translated to care for Cherokee citizens relative to administrative costs? In other words, what did we actually get for the money that Cherokee Nation contributes and shares to the Claremore Services Unit?
Well, sir, I think we need to figure out number one before we can
Okay.
calculate number two. So if you get with Lindsay and we can get the actual dollar amount associated with the shares, then we can sit down and start figuring out visits.
Okay. How does the council learn what the rate of coverage and denial for applications to purchase and referred care is for the past 5 years?
I can have the PRC staff figure that out. And now, do you want that just for Cherokee Nation citizens or for everybody in particular? Everybody?
Cherokee Nation citizens.
Okay.
Yeah, I think we already answered for amount of shares represented by the budget passed by council, because obviously the money for Cherokee Nation goes straight to IHS. What advantage are there, if any, they're utilizing this Claremore-based system as opposed to what we use here at Cherokee Nation Health Services?
What advantage?
Yep.
I don't, as far as PRC?
Yeah, or overall, what's the difference between going to Telequal? What advantages are there going to Claremore versus those?
Well, we still see any federally recognized tribal member, just like Cherokee Nation does,
Yeah.
as far as services in-house within our four walls. Where we tend to get just more diverse is on the PRC side, where we have a little bit, we're involved more with more tribes and the non-Cherokee tribes there. And again, we have different boundaries also.
So it's really like advantage, I mean, for Cherokees, it's really not much difference as far as services.
No.
Right, okay. So we pulled up the budget, it was an annual budget, and it's 40 million, and Cherokee Nation's part of that money is around 30 million. So that's 75% on that budget that they showed us,
Okay.
right? But then we're talking about services, and I know a lot of that's admin, infrastructure, and stuff like that. But if $40 million of budget, and we're paying 75%, but then our denial rate is over 50%, what are we doing
Well, you're talking about an overall budget and then PRC numbers.
overall? The one we were looking at, we have one here that
Well,
we
you
got.
said a denial rate.
Well, we
that's
looked at the
PRC.
denial rate and calculated, and it shows every time there's a denial, it's over 50% that's
Yes.
applied, right?
Mhm.
Okay, so I'll get those other ones from you, but those are the questions that I wanted to ask, so I will get with Lindsey King after you send me that number.
But we don't get $40 million for PRC.
Right.
That's an overall, you're talking about two different things. You're talking about an overall budget,
Right,
and then the 50% denial rate is based on the PRC budget, which is completely different
they're
than.
two different things, right?
Yeah.
Okay.
You're talking about apples and oranges here.
Okay. Well, these are just some of the questions I was wanting to ask to try to figure out the benefits over
Sure.
there, so.
Sure.
That's all I had, Chair, for that. Ovia Dobbins, Counselor, sorry. Thank you.
Just for clarity, George, PRC, what does it stand for?
Purchase referred care.
Purchase Referred Care. What else do we call that?
That's the new name for contract health.
Oh, that's the new name?
Yeah, they changed that a few years ago.
Okay, hadn't got down to Talakoa yet, I guess. Okay. And you mentioned the area office, Claremore function, Oklahoma City is the area office for Claremore?
Say that again?
The area office you mentioned, the area office for Claremore is Oklahoma City?
Yes, yes, sir.
Okay, all right,
Absolutely.
okay, all right. Danny?
Afternoon, George.
Hi, Dan.
Are we still any closer to getting the person that you told Counselor Deere that he needed to ask? Is there any way that we can actually get all these folks into the same room at the same time where they can answer these questions for us to where we understand what's going on?
Yes, sir. Yes, sir. I had reached out and talked to somebody about that, and then I think you guys had asked me to put that on hold until you got the information you had asked. So whenever you guys are ready to do that, I'll try to pull my end together and get with, I can't remember who it was I talked to down here now. One of your attorneys down there said he would take care of. John. Hey, John. I'll talk to him. He said he would take care of pulling this side together, and I would coordinate my end of the IHS side. We could all get together. So, no, that's absolutely the best way to resolve anything.
Because I know with us, you know, we've got to, if we have somebody on the northern end of the reservation that gets a denial, they've got to fill out 2 papers, two appeals to you guys before the Cherokee Nation down here will take care of their situation. So I think one of the issues is with this amount of money that we are providing in our behalf, even though we're not writing you this amount of a check, but, you know, did you tell me 60% of your cases are Cherokee?
Something like that, yes,
Something
sir.
like that, you know, so I think that's where the question comes from, is why the denial rate is so heavily toward the Cherokee people, with the simple fact that we're producing this much money into the IHS facility. I think that's a big question that we're trying to get to and get to the bottom of. Does that make sense without, and I know you're probably, you know, with all this money and all these other, you know, these other bean counters and things that they do all this stuff with, you know, we need to get to some point to where Councilor Joe Deere's questions are actually answered, so we know where we're at and what we're doing.
Agreed. I was just looking at the report that it's there for that month. Around 240 Cherokee Nation patients went through PRC, and only 22 of them were denied.
And when they do get denied, how long is it going to take to pay the bill that when they get referred over? That's a question that we're having, because I mean, and we won't talk about it on the air, but the point is, I've got people that's had you know, that still haven't got their bills paid, and I just don't understand where all this is coming from at this point. So I mean, that's why we need to, and I'm sure you don't either, because that's probably out of your realm, but those are questions that just keep popping up with people.
Well, now, if they've been approved, out of that 211 that have been approved, if any of those 200 and 11 are getting bills, still not getting something paid, I need to know that. We need to bill for that so we can get purchase orders cut for that and get that out there.
And these 211, is that per month, or is that the whole year up to this point, or what?
No, sir, this is a monthly report.
Okay. Now, if it was a year ago, is there 211 out of, what'd you say, out of 240? Have they, is this average that you're telling me, 200 and whatever got approved? Is this a normal percentage that gets
No,
approved
sir,
out of Claremore?
this is not an average. This is the last month that I put in this report. What I give you is for 1 month, a 1 month time period. And every month that I turn that in is for that 1 month. So this is not an average. These are actual numbers from that month.
Thank you.
Thank you, Mr. Chair. Thanks, George, for being here today.
No
I just
problem.
want, for everybody's edification, I think it's important that we just explain this piece of paper that was dropped on your desk. I don't want to go over the numbers individually, but just so everybody understands, I just clarified this with George up there. But the first 2 lines, the hospitals and clinics OP and hospital and clinics IP, that's infrastructure and salary and HR, and that's, you know, what it costs to run Claremore and for those 2 things. We're still going back and forth on dental, but then when you go down to the bottom 2 lines, the purchase and referred care for outpatient and inpatient, those are the funds that we're paying vendors. We're paying other people to actually perform that work, right?
Correct. Yes, sir.
Okay. Just so everybody knows as we're going through these numbers what they mean, and you know, hopefully through our FOIA requests or our GRA requests, either one, we can get a little more granular data on what happens there. But right now, this is kind of all we've got to go on. And generally speaking, Mr. Valier says that this is pretty close to being right. But just so we all understand what we're looking at, those top 2 numbers, the biggest 2 lump sums there, those are more operating costs and salary costs, HR and infrastructure, as we move forward. But that's all I wanted to add, Mr. Chair. Thank you.
Hey, George, appreciate you being here today. Yeah, just kind of clarify a few things that what I've seen here and some of the questions have been asked. I know that we're a federally funded hospital ourselves, and that money flows through us on into you to pay for the services rendered to our Cherokee citizens, and obviously, at the rate that you said, roughly 20 denials out of 211 seen that month. That's a over 90% approval rating for contract health. So appreciate you getting those citizens taken care of now on. I know, Danny, you deal with Claremore a lot more than I do, so you have more knowledge on that. However, I will have to say that, like what George was saying, there are several on a monthly basis that I'll get that are case-by-case referral denials that you're going, why are they getting denied, or why haven't they got paid yet? And I can't say anything other than, I know I work with Mr. Carey on our contract health down here in Tahlequah a lot. There's a lot of citizens that get taken care of through contract health. There's bound to be a dust collection of them that get through the cracks, that don't get caught. And I know Mr. Carey's been good, and George, I know you've been good too at making sure that we've getting contract health approval passed and making sure that they get paid. It's just, there's a lot of case-by-case basis that we have to take care of, and we're glad to do it. I'm glad to do it. I'm glad that I know with confidence pretty much every time I've sent over a denial for a contract health, even something silly as Cherokee Nation takes one of our citizens by ambulance from Cherokee Nation Hospital to another facility, and they get a bill for that. Now, that doesn't sound right. We all know that doesn't sound right. But I've emailed over there, got contract health to cover it. I think we all just wish that and hope that there's no citizens that don't get a hold of us or don't get a hold of you and your department. They get it paid for. But it sounds like basically you're doing a great job up there of getting our citizens' approvals paid for, and we're using federal dollars to transition on you guys to take care of those clients. And there always is still going to be some that fall through the cracks, even though we wish it wouldn't happen. But we're glad that you guys have been there, and Mr. Carey over at our health system has been able to approve those referrals when we're able to get a hold of the customer there. So just kind of wanted to clear that up of what I've seen going on, and appreciate you. So appreciate you, Chair.
Thank you.
Okay, Danny.
George, we met with our health committee, Mr. Steve Carey, a couple of weeks ago, and I asked him the same question, so I'll ask you, why, when somebody is contracted out, and you may have this answer from what they didn't have, but why do we have to sign a paper when you go to a contract doctor that says you are responsible for this bill if the nation doesn't pay? Or if Claremore doesn't pay? Is there somewhere, if we're in the middle of paying this, and I ask our people the same thing, why do we have to sign that? Because if you're late getting a bill, I think Councilor Legg had brought up a question a month or two ago, why are we the citizens the ones that's getting hounded for it when it's supposed to be paid through contract health? Is that something that we can work out and get this situated out to where we don't have to sign the paper because they're the ones sending us over there?
That's a good question. I'll be glad to raise that up to area and agency and get a specific answer for you. You bet.
I would like to make a comment, and this is something that I've learned about contract health. So we have service agreements with independent hospitals, and Steve, if I'm wrong, please correct me, but let's say it's a shoulder surgery. We're going to say, we're going to send you so many shoulder surgery patients a year, but in the scope of things, we're going to pay $34,000 for this surgery. They agree that that's the amount because we're sending so many people there. Then we pay $34,000, and then the doctors that they send us to, or the lab people, or the x-ray people, start sending us bills on top of that, that then we have to contact Steve Carey to say, hey man, can you help with this? Well, that wasn't even, we was not even supposed to be billed that. So it's not like it's contract health's fault that we're getting those bills. It's the providers that we're using, correct, Steve, that sometimes break their agreement with us and start sending us bills that they're trying to hold us responsible for. And technically, if we don't send them in to contract health to get them taken care of, yeah, I like what you're saying though, like, let's just say, and then Cherokee Nation can stop having us sign those agreements and have contract health negotiate and say, do not, mess with our folks. You send those to us. We'll pay them if we want to because you're breaking the agreement, but don't put it on the burden of the folks. And if that could work, I don't know, but I'm like y'all, I've been so enlightened on contract health with so many of these folks, but it's not that it's contract health's fault. It's the people that we are contracted with at a certain dollar amount, putting the burden on us as patients or, our constituents as patients to pick up these extra tabs that they're trying to throw our way. So like I said, I've just been enlightened to a lot of these things myself over the last 3 years, and if there's anything this council can do to help y'all, let us know, and we don't mind doing that one bit. If y'all need a stronger backbone to, enforce some of these things that y'all are trying to do for us anyway, let us know, and we'd be glad to help you.
Thank you.
I guess the confusing part about all of this in the last 4 years is the majority of the denials that I deal with comes from Claremore. And, then you have to go through that process of getting denied twice before the Cherokee Nation can look at it. But then in about 99.9% times, we end up paying for your denials. I mean, we do. And in the cases I've been involved in, I don't understand if the process is the same at Claremore and here, I don't know why are we paying for your denials? I mean, why didn't you pay for, how can we pay for it and you not? I mean, I don't understand that. I've never understood that. Because that's just the way it is. That's what I've dealt with. How does that happen? Or do we have a different standard? Here is there. Are we more easy?
No, we have a finite amount of money to spend each week. And we start paying with the most acute cases that week, and we pay until we run out of money. End of story. The doctors in our review committee every week rank those, and the PRC office starts paying at the most severe and goes until they run out of money. And then we can't spend money we don't have.
What do you get a month?
Well, I think we get about 7 million, 6 to 7 million a year, and we just break that down into 52 weekly budgets.
Could you get that number, what you get a month, if you
Sure.
would, for next time?
Sure, absolutely.
Thank you.
Mike, to Mr. Shambaugh, to answer, at the beginning of the Baker administration, there was a act passed for us to have 5% of our business profits to go to, I'm forgetting the details, but 5% of our business profit goes into contract health. They don't have that. So they are paying what, if we were just relying on the federal portion, we would be denying at the same rate they are. But they don't have that. We do. We have made that commitment to set aside 5% of our business profits for contract health. And so as our businesses grow, the pot of money for contract health also grows. I know I'm probably not relaying the details just exact, but I know it's pretty close. And so we do have a substantial pool of money that they don't have for that purpose. So if we also had the same limitations, we'd be denying at the same rate, I suspect.
Well, I think that's the whole point of asking the questions is why. I mean, you know, I don't know the answers. I don't. That's why I'm asking. If that indeed is true, it may be time to look at how much we fund and what that funding goes through. I don't know if it wouldn't be in our best interest to purchase that. I mean, IHS. So, I mean, there's a lot of things to look at, I think, that we need to look at, and maybe it's not, but that just always struck me odd. If that's the reason, then I appreciate the info on it, but I just found it, and we have talked years ago about money, and I had asked you here a while back if the reason why most of these were being denied was money, and you told me no several months ago. But, so I don't, that's where my confusion was lying with this. So maybe after we get some of these questions answered, I mean, we may find a more efficient way to do business, maybe a more efficient way to help you out. So maybe that would be the end result of it. So, and it would be a win for both sides.
Yeah, just to follow up with Councilor Austin said, we also we're able to bill insurance companies. So, because we're insurance companies, if you looked at last year's budget, you'll see a carryover of $180 million from our healthcare. So $180 million is profiting from Cherokee Nation's healthcare systems, which allows us to help out places like the Claremore Indian Hospital there, just like other servicing agencies that are outside of Cherokee Nation. In fact, one of them's Peaceful Warriors Way here in Tahlequah. I refer people in there that have addiction, and we help fund them subsidies and also help them be able to coordinate services outside of our own control, because Cherokee Nation has a lot of money. There's a lot of hands on deck that are outside of just Cherokee Nation's ownership that help, and because we have that excess funds that we're able to accumulate from insurance, I'm glad to hand it off over to George and them and to make sure that we're able to get those things taken care of. And I think there is a little bit of a, at times, like, I get phone calls from citizens up there saying, why am I having to go through this process of getting denied twice? Well, it's still a federal entity, just like Cherokee Nation is. If you don't have insurance, you're still going to have to go through a referral process, even with Cherokee Nation. If you don't have insurance, you're still going to have to go through a denial process there too. They just have to deal with it a lot more regularly because they don't have insurance provided clients that they're able to take care of. So that just should clear that up on the funding side and why they have to go through that process of denial versus us may not seem as much, because a lot of our citizens that go there, they're employed by Cherokee Nation or somebody else that has insurance, and Cherokee Nation bills them instead of having to wait for a denial for a referral before they get that funding approved. So appreciate it, Chair.
Wes kind of stole my. I'm sorry. That's okay. But from my experience with IHS, or even any doctor, is, there's no guarantee that IHS or anybody's going to pay for it. And that's why they push insurance, people to have insurance. And my thinking is, take the slack where there was no insurance to pay for things like that. And I know the IHS always had criteria of certain things that happen that is no guarantee that they'll be paid for, is what my experience in the past, with IHS.
That's correct.
Well, George, you and I had a conversation. We'd probably sit down and have a cup of coffee and just enjoy each other's company. So, and I'm very appreciative of IHS Health and the Cherokee Nation Health. Here's what folks need to remember. Half of the reservation goes to Claremore. Okay? Half of it does. So half the money that the Cherokee Nation would use for contract health is used from from the middle of it, south, and it goes. So everything that goes through the Cherokee Nation of this contract comes from these upper counties in the northern part of the reservation. So for what money they get to what money that the Cherokee Nation has, you know, they don't have near as much, but they're dealing with a lot of different counselors, a lot of different districts that goes up. I've never minded helping because that's why I become a counselor. You know, and the point is, insurance, I was told that insurance should not qualify you to where you get contract health or whether you doesn't. That's not a factor, is it, George?
No.
Should not be. So we need to bring that out right off the bat, because if you have insurance, whether you do or whether you don't, it should not be. Because I've had insurance for the past 10 years or so in education, and I still use the AMO clinic in Salina, and I'm very proud to use that and have been taken care of and go through that. But with that said, the only thing we're looking at here is the fact that half the reservation, if it comes to the right thing, has to be denied twice before the Cherokee Nation can look at it. So they're going through 2 more steps before people here has to do that. And and to be real frank with you, a lot of people get denied once, they're not going to ask again. Then it just goes on. So I'm just saying we've got a few holes that we fall through, a few things we slip at. You know, being an old football coach, if you don't improve yourself from game 1 to game 10, you're not going to win very many. And I just think this is an opportunity for us to help with the contract health and make these things better for our people that we have to serve. Thank you.
Thank you, Mr. Chair. I think it's important that we go back to kind of why we started this conversation. And while I understand the whole idea about it making money on third party, I mean, look, it says in the report that, we're moving in on $34 million in third party revenue for Claremore. That's great. We understand all that. But, you know, most of this is anecdotal evidence that we're talking about. But I can tell you what is not anecdotal evidence, and it's the data. And I can tell you what this month's data tells me about Claremore Indian Hospital. Okay, it tells me that the patients were less than 50% seen were Cherokee Nation citizens, less than 50%. 10% of those were denied. Okay, but yet we pay in shares 75% for Claremore Indian Hospital. That's what the data tells us for this month of empirical numbers. Now, we can go back and extrapolate that out and look at the last few months, but that's what it tells us for this month. We paid in 75%. We saw 50% of the patients were seen, and of those 47% that were seen, 10% of those were denied. That's the numbers that we have in front of us. So that's why we started this discussion. It's not about third party. It's not about any of that stuff. It's about those empirical data, those numbers. Mr. Chair, I just wanted to bring everybody back to that. Thanks, sir.
Thank you, Counselor. Keith?
Counselor Kidwell, I question that logic. I just respectfully, because I don't think a whole bunch of people whose services were cared for within the 4 walls of that facility, they wouldn't show up in that denial, because their service was taken care of underneath that roof. So the budget for those folks would not show, they wouldn't have had a denial because everything was taken care of under the roof. If it's taken care of under the roof, there's no denial process, correct?
Correct.
So I'm not sure that truly is an accurate breakdown. I think it just requires a little more digging.
Go ahead, John.
Mr. Chair, and I would agree that we need to dig into it more. I mean, the numbers that we have in front of us tell us that. Do we need to do more investigation? Yes, we do. And that's why we're trying to get all this this information out. Thank you, Chair.
Joe?
So is it true Creek Nation pulled their shares out?
Yes, sir.
Have you seen a difference or higher or lower of Seeing Creek citizens? Or do you just see them, or what's the process now?
We see any federally recognized tribal member that comes to the door.
So they're taken care of anyway, regardless if
with
their shares are
services that are in the building.
right?
Yeah, they are completely out of contract health, out of the contract health arena. Any Creek Nation citizen that gets referred out, that referral goes directly to Creek Nation.
Okay. Thank you.
Mike?
Explain shares. What does that mean, you pull your shares out? What does that mean?
For them, it was easy. They took 100% of any remaining shares/funding that they had in the service unit out. So now they have no money in the service unit.
So basically, shares is just funding.
Yeah, yes, I'll say that today, yes. Lindsay will probably give you a different explanation, a definition of that, but yes.
Okay.
For this conversation, yes.
Okay. Okay, before I let you go, George, I was noticing page 4 of your report, it addresses in dental. It says that dental has been incrementally reopening. I notice we're still not approaching pre-pandemic levels in terms of patient visits. What does it mean? Why are you incrementally reopening?
That's what the dental guy down in Oklahoma City told them. He told them to hold back and just open up incrementally as we went forward. That's what he from the governing board had directed us to do. So that we're slowly opening it back up to full speed.
Okay. You've got a full dental staff, but you're just incrementally reopening.
Yes, for the dental anyway, yes.
Yeah.
Everything else is running full speed.
Okay, all right. Any other questions for George? Thank you, George.
Thank you.
Cherokee Nation Health Services, Dr. Steve Jones. Hello, Dr. Jones.
Good afternoon. Well, I'm going to go over a few things on our report, and I know you guys have a full day and a whole lot of meetings today, so I won't keep you too long, but I want to talk a few things. So first thing is thank you all that participated in our contract health seminar that we set up for you for that week. Those of you that took advantage of that time, you got to spend one-on-one with Mr. Carey, I think was beneficial, and I appreciate you guys taking the time out of your schedule to do that. That helps us because it helps you, and helps us to be able to talk the same language and understand the rules that go along with that. So I appreciate those of you that took the time out to do that. We had the Wilma P. Mankiller Center open up, or health clinic open up, and did our grand opening. I think some of you attended on that. So we're very proud of that, and the staff is very proud to get out of the temporary buildings and be functioning and working in their new facilities. So all of our construction projects across the nation are still on point or on time, the ones that we're doing at all the different clinics. So just give you an update on that. The other thing that's probably important for you to know that you probably got calls on or may is that we have implemented back into our masking protocols at all of our healthcare facilities and our visitor protocols. So when people come into our clinics, they're asked to put a mask on. And we have some metrics that we've set up to that we'll continue doing that until we see the numbers start coming down. I'm sure Dr. Gann's going to speak on that, so I don't want to take away from his presentation. A few things I do want to talk about is we've hit 108,800 as of this morning on vaccinations that we've given. Some of the things that we talk about routinely is the provider vacancy rate. It's a little higher this month, as you can see. Part of that is due to people fulfilling their contracts or fulfilling their scholarships and either moving on or us not renewing because they have other interest or because they just did not fill in with us or meet our philosophy on how we practice. So you'll see that will fluctuate a little bit over the next few months. This is the time of year when contracts start coming due and obligations become fulfilled. So some people choose to stay, some people choose not to. So just to let you know. The other thing on the approval rate on contract health, we can see that number is 96%. It stays right around 96 to 97%. Just to give you some reference, our contract health referrals were around 14,000 for that month. So 96% of 14,000 when you look at those numbers. It's a little bit different. I don't know that I heard someone say that I think half of our citizens go through Claremore. I don't know that I agree with that number. I'd like to see something else on that because our our numbers obviously are across our system are far greater than that. If you go to the next page, you can see that our ambulatory visits are all growing or stayed steady or increasing. And then the next one on our revenue, you can see that our revenue at every clinic is growing. For our third-party revenue for year-to-date, last year this time, we were at $108 million. We're at $147 million this year. So you can see that our revenue, our third-party revenue is growing, and we try to make sure that we are collecting everything that we can collect. One of the things you talked about with the contract health and having insurance, there is a component of contract health where we are the payer of last resort. So there is a component in there that we ask people if they have insurance. Not that it's going to qualify or deny them, but so that we can collect on that and make those contract health dollars go the farthest they can. Because if the bill is $100 and the insurance is going to pay $60, then contract health is only going to pay $40. But if there is no insurance or no third party to collect, then the contract health is going to pay $100. So that allows us to serve more people and go further, and that's why we are the payer of last resort. So that's why those questions get asked. It's not because we're going to deny or approve you based on whether you have a third-party payer. So I just want to clear that up. And the other question that was asked was, why do we have these letters signed that you may be responsible for a bill? So if a person comes to one of our services and they're from outside of our jurisdiction or outside of our boundaries, our reservational boundaries, and they get referred out, then they're not eligible for contract health. And they are going to go out for that service if they choose to, and they will be responsible for that. So that's why those disclaimers are put in there. We don't always know where someone resides when they come in. Our docs don't look at that. Our docs treat every patient the same. So that is why that happens. There are rules that go along with that. And if someone gets out, is not eligible, that's the law. We can't go and make them eligible. And what you were talking about being referred out, yes, we have a problem with outside referrals right now. We're putting in systems to put a gate on that, but we have a lot of people that we refer. Let's say we refer somebody to an orthopedic surgeon, and that orthopedic surgeon decides they want a different lab or a different image done of that area that they're going to be treating. Instead of sending them back to us and letting us take care of that, they send the patient down to their service, and then they send us a bill, and that's not appropriate. We provide that service. The agreement is they would send them back to us, let us run that lab, let us do that image, and send it back to them. So that's what you're talking about, where we're getting caught in this crossfire, and it's part of it's educating our providers that we contract with. The ones that we've contracted with for years know that, but the newer ones, they tend to do it their way. And so it's part of that educating. Now, unfortunately, the patient gets caught in this. We're cleaning it up and trying to put in some gates that make those referrals manageable and let us double check them before they get sent out to make sure we can't go ahead and provide that service before it gets sent out and we get billed for it. So we're cleaning it up, but it's a very difficult process because it's a broad problem that we've identified, and it's not easily fixed. The other thing I want to point out is just that our ED and urgent care, you see those numbers over the last few months have been dropping on our left without being seen. So we have fixed some issues with access, and we're getting people processed or through that system a little quicker. So with that, I'll turn it over to questions and anything that you guys might have of me.
Danny?
Dr. Jones, your last statement about falling in between the cracks on your provider and the patient, the problem with that, and I understand there's problems, but you get an elderly person that goes in and they perform an $1,800 test on her. She doesn't know what the referral reads because as we read these, I mean, they're very difficult for a layperson to understand in the first place. So she may not have $1,800 to pay this person, so her credit is totally ruined from a misunderstanding.
And I totally agree with you, and that's why we're trying to put some checks and balances in there, because we tend to not find out about this until you find out about it, because the patient doesn't come back to us with it either. And if they do, then we try to get it fixed immediately. But it is one of those things, and maybe they don't let us know till they've got the third notice. You know, they've been sent this bill and been told they owe this bill, and they say, oh, Cherokee Nation will pay it, and they throw it away and comes down, then all of a sudden they get a claim or a credit issued, where they're it's gonna be against their credit, and then they bring it to us. So it is a problem, and we're trying to figure out how to fix that. There was a time that all referrals from outside docs had to come back through the provider, and the provider had to approve that. Whoever the provider was for that patient had to approve that, and that slowed the process down so much that the patient couldn't get the treatment done because they were waiting on people to give approvals. So then the pendulum has swung this other way, where now it's an open checkbook. And these providers are sending people out for all types of tests and images and whatever else that they desire, without any check and balance on it, and they just expect Cherokee Nation to pick up the bill. And so we're working on trying to figure out a way to put a gatekeeper in there that's not going to slow our providers down, that's not going to slow the patient from getting treatment down. And we're trying to find that balance, that very fine line to walk, because we want our patients we want our providers treating patients that are in front of them, not sitting on a computer and approving referrals all day. So it's a very fine line that we're trying to figure out the best way to move forward so we don't slow down any treatment.
Dr. Jones, Counselor Shot Pouch mentioned about encouraging our constituents to sign up for the Affordable Care Act. Do we still offer that service at all our clinics where they can very easily get signed up there for the Affordable Care Act? And can you give us roughly what kind of financial commitment that would be on most of our citizens, do you?
To answer your first question, yes. Every one of our clinics has people set up to do that. As far as the financial commitment on each patient, that depends on income. There's a lot of variables in there. We have been able to find in some cases that people get no-cost insurance.
Yeah.
Which means, and we encourage them to sign up for it. We don't have any rules that make them do that, but we do try to encourage people that if they're going to get an insurance plan at no cost, that helps us help more people. So those are some of the things that happen. But we also have a group that's working diligently and calling our patients that are uninsured or have no third party and seeing if they qualify for Medicaid with the expansion of Medicaid services. And that has helped tremendously because we found a lot of people didn't even know that they qualified. And not only does it help us, but it helps them with other services that are provided through the state. So we do have groups that work on that daily.
I think a lot of our constituents, even generationally, their mindset is, well, the tribe's going to pay for it. And they don't even consider other options, and they qualify for these other options. So, and I'm sure we're doing the best we can to get the word out. I saw something, Dr. Jones, I guess Paxlovid is kind of the go-to therapeutic for COVID. The FDA put out a statement that they are allowing pharmacists to prescribe that Paxlovid. Were you aware of that? And if so, do we do that in our system?
I'm not aware of it. Dr. Gann may be able to speak a little more to it. Dr. Montgomery couldn't be here with us today, or I was going to have him in case some of these type of questions came up. I do know right now, whenever I've gotten calls of someone who has tested positive and is interested in getting Paxlovid or something, that we do set them up with a physician, either their primary care physician or someone through our screening clinic that a physician can have, or a provider can have a visit with them. There are some contraindications that need to be considered on that medication, and a lot of our patients fall into those areas where those contraindications can be impactful.
I was surprised to see that. I wasn't aware of a precedent where FDA gave the green light to pharmacists to prescribe.
I'm not aware of that, if that has happened or not, but I'm not aware of that.
So in our clinics, who could prescribe?
Our providers.
Well, and they are the physicians, nurse practitioners, physician assistants?
And they work underneath, any of our mid-levels work underneath a physician.
Right.
Yeah.
So in our system, our pharmacists cannot prescribe?
To my knowledge right now, no, we're not doing that.
Daryl?
Dr. Jones, how many of the new COVID patients that we have are on ventilators?
I don't know of any patients that are on ventilators in our system at this time.
Good deal, good deal. That's what I was wondering.
Got a question? Okay, go ahead, Wes.
We service, Indians of all tribes, don't we?
Yes.
So, yeah, I
Any
grew up.
any federally recognized.
Well, I'm
tribe.
sorry, yeah, yeah, gotta be clear on that. I grew up, my whole life being born in an Indian hospital, being served by Indian hospital all the way through until college. So since that said, because we don't deny, just kind of a clarification on the last conversation that we had with George, since we don't deny, any other federally recognized tribes, it doesn't matter whether you're Cherokee or Creek citizen or Seminole citizen. So our money that we're getting allocated from the federal government and other resources, we're able to distribute that out there and try to help as many Indians as we can. And that being said, so whenever we do send money over to help out over at the Claremore unit, that may not be going directly to service Cherokees, but it goes to service all federally recognized tribes that you have over there that you recognize the same as under our umbrella. So when the money moves from here to over there, it's still servicing. It's not that this money is set specifically just for Cherokee individuals. It is for all federally recognized Indians the same that it would be over there, so.
Okay, so let me address that. So we're not moving money over into Claremore.
Right.
That money is given from the federal government, and if I can help George out a little bit on one of the questions you asked him, you got to think of shares as equity,
Okay,
okay? Shares aren't, you can't think of it as we're buying shares in a company.
right,
You got to think of it as equity, and that equity is based on the user population, what percentage of that user population are Cherokees.
gotcha.
Okay, so when the Creek Nation pulled their percentage out, our percentage went up because they're no longer considered in that pool of money to be equity in that clinic.
Yeah, okay,
So, so the way that they handle things and the way we handle things are a little different because of what someone had said earlier. I think it was Counselor Austin, the 5% money that comes from Cherokee businesses for contract health, that is a Cherokee-only pot of money.
right,
Even though but the other money that we
Right.
use for, from the federal government for contract health,
Right.
that is for all
All
federally
federally
recognized tribes.
right.
Yes.
Okay, awesome, appreciate
Yeah.
you clearing that up for us. Thank you.
But that 5% is strictly not used on contract health, is it?
It's used various ways, but if there's a way that benefits contract health, then we can use it for that. But it does have specific guidelines that was given by this body.
Right, well,
On that
that's
money.
my whole
Yeah,
point, is
yeah.
it's not just for contract
Right.
health, it's for other things too.
Yeah, and that specifically was given by this body.
Right.
Yeah.
Right.
But
Okay.
I guess my point is that was made for, since it was Cherokee money, it was made for Cherokee citizens. It doesn't go into the pot for all tribes. It goes for Cherokee citizens.
Right, and I just wanted to make the point that it just wasn't contract health, it's used for other things too.
Absolutely.
Okay.
Yeah.
Hypothetical. Did the Creeks, the money when the Creeks citizens, when the Creek Nation pulled their shares out of Claremore, did that money go to the Creek Health Facility, or does that just get washed out into something else?
That I don't know. That's part of, the money goes, my understanding is once they compact it, it goes straight to the Creek Nation. So how they decide to do it, that's up to them and what the rules of the compact are, or what the negotiation of the compact was.
So the money that we had on this piece of paper here, if we pulled out of, hypothetically, out of Claremore, that money would be put back into the Cherokee Nation healthcare for you guys to use here?
Hypothetically. It would be all part of just like when we compacted Hastings Hospital, there was a negotiation that went on between Cherokee Nation and the federal government, and all the terms of that negotiation and that compact were decided between those two entities.
Sorry to ask you a hypothetical situation,
Yeah.
but thank you.
Hey, Doc, I got to spend a couple, 2-3 nights in Hastings here recently, and would really like you to convey to your staff that, man, it's top-notch stuff. I mean, we talk about health all the time, but when, actually laying in that bed, there's some superstars you got working down there, and that ICU, those ICU nurses and, of course, the docs, man, they took care of me. So
Great.
just convey that to them, and like I say, it's eye-opening. We can talk about it all day, but unless you're there and seeing what they're doing, it's sure a good feeling knowing that we got people like that take care of folks.
Well, I appreciate that very much, and I do appreciate it when you guys send me compliments. I do send those to the staff and to the departments when you send those to me so that it can get right to that person that you're complimenting on. And it does mean a lot to them, so I appreciate anybody that sends us the positive things that they hear or experience. It makes a huge difference, and I get feedback from them thanking me for sharing that with them. So I do appreciate it when you share those. Thank you.
You did bring up the word compact. When we did Hastings, we did a compact with them, talking about no fire over there. You know, that money goes straight to Claremore, which is correct. Then when you compact it, it goes to Telequal. Those are the two different situations, right? Because the hospital makes a profit, correct?
Our hospital?
Yep.
Not right now.
But,
I mean,
or else we wouldn't be in
are
that
always
business,
looking
right?
to try to break, honestly, with our hospital, we're looking to break even.
right.
You know.
But you know that, or else
yeah.
we wouldn't be in that business.
Yeah, we're trying to get, all the third-party revenue goes into one pot.
Right.
So everybody's contributing to that. But typically, hospitals are a little bit more difficult to get them to break even because the services are much more expensive.
Mm-hmm.
And the reimbursement rate for us, because the way we're structured, is much less. Then we don't bill fee for service. You don't get billed for every gauze and every Kleenex and every, gown that was used for you while you were in there. It's a one-time, all-inclusive rate, and so it's a little different for inpatient than it is for outpatient.
Okay, but that was the process to compact with
It
Hastings.
is.
That's how it worked. So with that on the table, what's stopping us from compacting with Claremore?
I can't answer that. That's not my decision.
Okay, but it's a reality that could happen.
Again, that's not my decision. I
Okay.
don't even want to go
All
down
right.
that road.
All right, there you go. Thank you.
Thank you, Dr. Jones,
Okay,
for your
thank you.
report. Thanks for coming and keeping us informed. Okay, sliding in behind him, Lisa Pivek, and I see Dr. Gann there as well today. It's all yours, Lisa.
Thank you. Good afternoon. It's good to see all of you today. I hope you're all staying cool and all your constituents are staying cool in this extreme heat, being careful. Thank you for having us today. There's a few things on my report that I'd like to highlight before I turn it over to Dr. Gann to give you an update on COVID. So if you take a look, I want to remind everybody that our new website launched on May 1st. We continue to add more stuff to that constantly. I want to thank Communications. They have a staff person that helps us maintain that website and take care and put stuff on it. There's a lot of information, not just for you, but for your constituents, for your schools, your community level folks to look at data and other things that are on there, and it will just continue to grow. One of the things is if you go, WIC just received new income guidelines as of July 1st, so some of the folks who did not previously qualify might now. So those income guidelines are uploaded on there as well to the WIC and the WIC applications. We are still working on accreditation, and we are almost ready to push the button for reaccreditation. This is hundreds of pages of work for each of those domains. We're excited to finally get it done. I want to say a special thank you out to folks from other divisions who really helped us get through our documentation, including environmental health, environmental programs, and emergency management. We wouldn't be able to do it without their help as well. All of our public health staff is continuing through what's called results-based accountability training. It's a new framework we're using for performance management. And as the months progress, you'll start to see our reports reflect more of that. It's training based on actual results that happen in communities and being able to show those results and in real time change what's going on as far as the types of interventions we're using and the things that are happening in communities. We have some training this week in which we'll have county level teams coming together that are within public health, such as WIC, our community health workers, our public health educators, our EPI teams, all working together, looking at one county to see how they can collaborate their resources and reach out to others to what's called turn the curve or work on different indicators of wellness in communities. Under the cross collaboration, that's one of the other things that we're working on, and we're working on that with other divisions outside of public health, and I've been talking about it for several months. But what this culminates to is a set of what we call Cherokee wellness indicators. So these are some of the baseline pieces of information that help form your health status. So they may not be directly related to your actual health status, but they're more related to education, to income, poverty, living conditions, housing, water and sanitation, community connectedness. And we're getting really close to having those completed, and I wanted to say a special thank you to not only health services, but commerce, education, language and culture, environmental health and environmental programs have been a key piece in this so far, and I look forward to being able to produce those and bring those to you within the coming months. As been mentioned several times over the last couple of months, we'll have the CDC, Centers for Disease Control and Prevention biannual tribal advisory meeting here at Cherokee Nation on August 3rd and 4th at the Chota Center. There'll be representatives from all of the people that sit on the Tribal Advisory Committee from tribes across the entire United States. And there'll be officials from the CDC, from their centers, institutes, and offices here as well. So it is going to be a very educational meeting. If you're interested, send me an email. I can send you more information about that particular meeting. I wanted to just give you a brief update on infant formula. I talked to the director of WIC this morning, and while they're seeing a little bit of an uptick in getting more formula on the shelves, they look to be probably January before they're actually fully stocked again. That's including any of the shipments that are coming in from overseas as well. And if there's any WIC participant that's having trouble finding the formula, our WIC staff are ready to help and can actually get it out to them, drive it to them, locate it, make sure that they have it. And if there's anyone else that's not a WIC constituent, they can help them find a place that might have that particular formula that they're looking for. If you look at the COVID-19 numbers, you will see an uptick from the month of May in the number of cases, contact tracing cases, daily calls to the hotline, and how many cases we're having. And that is just through June 22nd. So there were some more that would be added to that. So Dr. Gann's going to talk to you a little bit about that uptick and about what we're seeing in the realm of COVID. Last couple of things I have to mention are that we did get funded for a new grant from CDC called Tribal Practices for Wellness in Indian Country. It's a project that we're working closely with the Education Department on and the Youth Council to do tribal practices for wellness. Public health educator, you'll notice we put a few more details in this month's report, and as we get a little further down the road, I'm going to ask for more so that you kind of see a little bit more of what the public health educator in your county is doing and other projects that they're working with in addition to the projects that are listed throughout the report. So if there are any questions, you'll see they do a variety of different things in every county and area based on what those particular issues are in that community or what the community is particularly interested in. Since this report has been done, we did have the Cancer Survivor Summit here at the Chota Center, and next month I'll bring you some more details on the numbers and all of the activities from the Cancer Survivor Summit. And the last thing I have on the report that I wanted to highlight is the Community Health Worker Program that is really a partnership with the language program, but it's also a partnership with Cherokee Nation Health Services as well. And these are community health workers that are out predominantly working with first language speakers and helping connect them to not only health services but other services as well. And if you take a look that up to date, since I believe this was a 2-month figure of close to 568 tribal citizens assisted during that time. We have about 15 staff. We have 3 pending and 2 vacant right now. And this is a pilot project that as we get through it and see the effectiveness of it, then we'll hopefully be expanding that a little more and seeing how we can take better care of those folks out in the community. Health Services has a list, and they have a great way of capturing every person that we make contact with. So our staff makes contact with someone at each of the health facilities when they find a need within a first language speaker, and they work together to help get that need taken care of. And if it's something that the language department can help with, we make sure they know too. So we work in collaboration, and it's so far been a great partnership, not just for getting people services, but really for developing trust and relationships out in communities. I think it's a positive step for public health to do more of that work. If there are no questions for me, I'm going to go ahead and turn it over to Dr. Gann because he needs to get you an update, I see.
I just got a quick question. At the community meetings, are you able to send people out to community meetings with some of this information?
We have been just recently sending them, yes. Yes, we
Okay.
have. Yes.
That's what I was wondering. I had a couple coming up, and I'd been asked if you guys were back out again.
Yes, we are.
Okay.
Yes.
All right, appreciate it. Thank you. It's good info.
Thank you.
Yes, thank you. Quick question. Looking at the tobacco cessation education classes, could that apply to people that are addicted to vaping?
Yes,
Okay.
yes, as well.
Good.
Yeah, it does. Actually, it should say tobaccos and vaping cessation as well. It does. And we're looking at some, we're looking at some innovative methods of doing that. The classes that we have where people report in person or even online are a little bit more difficult, but we find that the one-on-one call in the quit line is what most people find the most helpful. So we're trying to work on an easy referral system for that.
Thank you. Thank you, Chair.
Thank you.
Good afternoon. So we're in another surge of COVID in Oklahoma. As of last week, we're averaging about 1,000 cases a day. The state puts out their data on Thursdays, which reflects the previous week. So the data is already old, but it's going up. Hospitalizations as well are going up. On Thursday, they reported over 200 people hospitalized in Oklahoma with COVID. Cherokee Nation, we're at about 70 cases a day. It's going up a few points every day. It's been doing that for a couple of months now. So it's a little bit slower rise than what we saw with the last surge, but it's still going up every day. Our positive test rate is 20%. We're testing between, on average, 370 people a day. And that average is creeping up a little bit as well. Like today, we'll probably test 600 people, but on the weekends, it's only 50 to 80 patients a day. So, we think this is predominantly the BA.5 variant. That's the one that's taking over in the United States. We've got some data on that. We know it's more contagious than what we've seen before. We know it's able to evade our immune system for people who are vaccinated or have had COVID before, or both. But it's still vaccines effective at preventing hospitalizations and ICU admissions. It was this morning, the report from the hospitals, we had 8 people in the hospital with COVID. Out of those 8, 1 was an incidental. It was a person that was there not because they had COVID. And for 6 of them, it was definitely COVID made them sick and they're in the hospital. And 1, it's kind of questionable. So it's there's some COVID pneumonia that we hadn't seen in a while with the variant that's been predominant for the last couple of months at 2.12.1. Right, but now we're seeing more pneumonia. We have the Paxlovid and 1 monoclonal antibody that's available, and so we have the treatments, have the vaccines available because they help. But the experts are saying now today with BA.5, the best protection we have, the most effective protection is masks. It's more effective than getting vaccinated, and it seems, at least in the local area, people aren't doing much of either. So it's time to be careful again and try to get through this next surge. I did see a report today, the latest variant started in India. It's in several countries in Europe, and it just showed up on the West Coast. It's called BA.2.75, right? So another Omicron variant, more contagious than BA.5. Which was the most contagious variant we'd run into before, and we don't have any data on how sick it's making people, putting people in the hospital, et cetera. So we don't know yet. And it's, so as we look at the pandemic and what we've been through and people getting infected and things calming down and getting infected, every time we have an outbreak, it's an opportunity for the virus to mutate and find some new way to hurt us. It was a movie I was watching the other weekend, and the quote was that Mother Nature is a serial killer. She'll keep looking for ways to make us sick. And there's ways we can keep ourselves from getting sick. We've got just health and nutrition, right? Being as healthy as we can. And then that whole list of things you've been hearing from me for years. Masking, distance, hand washing, avoiding large crowds, getting vaccinated. If you're having symptoms, get tested. And if you're sick, stay away from other people. So all that's still there for us. None of that has changed. All those things still work. The other thing to keep in mind is that most epidemiologists are estimating that the actual number of cases are 2 to 5 times higher than what's being reported because a lot of people test at home, and that doesn't get reported to the government, or they don't test at all. So So that 70 a day is more likely 150 a day is what's actually happening in our community. Now, the CDC community risk levels that get published every Thursday evening, as of last Thursday, the 14 counties of Cherokee Nation, there are 3 counties in the high category. That was Ottawa, Craig, and Rogers. And then 6 in the medium, Mays, Adair, Cherokee, Sequoia, Muskogee, and Tulsa. And then the other 5 were in the low category. And that's a combination of cases and the number of people hospitalized. And that data gets old pretty quickly, too. There's a different map called community transmission levels, which is just the number of cases, and we're all in the red for that. So as hospitalizations go up and the CDC maps catch up with the data, we will likely all be in the medium category or higher by this Thursday. And then I don't know when the peak's going to be. I just can't tell. We put our heads together and run the numbers and look at other states and what's happening. They say in the United States the peak should be the middle of July, which is this week, right? But Oklahoma, started later than a lot of other states, and so we'll see. I'll keep you updated as best I can. That's all I had, Mr. Chair.
Doctor, are we still requiring, like, dental patients and everyone to get a COVID test as they come in?
I think that's what they're doing. I don't know if it's everyone. It might just be people getting aerosolizing procedures.
Did you say maybe 600 you might test today?
Yes.
Okay, now, out of that 600, how many of those are going thinking they have COVID, or how many of that number is just our patients that we're seeing we're testing?
Well, for dental, I think we're about a third of that would be dental. And then some people are getting tested because they've been exposed, or they have a symptom and they don't have COVID, but they need to know. And then others like, yeah, I got COVID, I just need it for work to get the official report. And a lot of people are, test at home and come get retested with us.
So it's not all people that's rushing down there thinking they have COVID. It could be a number of.
Yeah, so there's that other block of asymptomatic people that are just coming for care. And of course, everyone who has surgery gets tested before surgery. Everyone admitted to the hospital gets tested.
Thank you, sir.
Yes, sir.
Dr. DeGan, do we have stats on the ages of the people who have been hospitalized recently? Children, elders, anything?
Yes, sir. I don't have the data on the tip of my fingers here, but yeah, we've got that data. What I saw today of the people hospitalized, there were 2 people less than 40, and the rest were over 60.
Okay.
Yes.
No children?
Not at Hastings.
Okay.
No. So we did have one last week who just was dehydrated. So I think when the state puts out their numbers on Thursday, they'll say, 212 people hospitalized, and they'll tell you the number of pediatric patients. That's less than 18. And as far as positive tests go, we track that very closely. We have this really difficult spaghetti diagram of each different age category week by week and what percentage of the positive tests are from each age category.
And are you currently offering the vaccines for all the way down to, is it age 2 now?
6 months.
6 months?
Yep.
And is that for the general public or just Cherokee citizens?
Anyone who shows up.
Okay.
I believe that's still our policy, always has been.
It is. I don't know, I didn't hear the whole response on the dental, on the testing. We are testing all dental patients that come through that have any chance of creating an aerosol for treatment. So regardless of symptoms or not symptoms, they're all being tested. I didn't hear your answer on that, but I want to make sure that you got the right answer on that.
Thank you.
I didn't know if Dr. Montgomery had told you of that update.
Yeah, thank you.
Yeah, so do you think there's another booster in the future? When's it?
Yes. Yeah, it's
How
either
long?
going to be a booster or a new vaccine. The variants are changing so quickly that the companies that make the vaccines, like if they started working on a vaccine for BA.5 now, by the time it's ready, BA.5 won't be an issue. So there will be something different this fall. That's what the FDA is saying. So we'll see. We'll see what shows up.
Does monkeypox do better in warm weather?
Thankfully, I don't know. I
Don't we
haven't
have one
seen
in
anything.
Sequoia County?
So You have one in Sequoia County?
Didn't we?
Wow, I didn't know that. What I know about monkeypox is it takes intimate contact to spread. So if you had monkeypox today, none of us would get it from you, just chit-chatting with you. And that they're vaccinating people at super high risk. People who are, take care of people with monkeypox, and men who have sex with men, and injection drug users that are in an area where there's monkeypox. They're at the highest risk.
Thank you.
Well, it's good to see you, Dr. Dan.
Good to see you as well.
I know that we have been seeing the numbers increase again with COVID, and of course, with the at-home testing, the numbers may be even higher than we suspect. So I've been hearing about rebound COVID and Paxlovid. Would you take a moment to speak to that?
Yeah, all I've seen are the case reports that this happened to this person. I haven't seen any data on risk factors for that happening. And it's definitely not a reason to not take Paxlovid, right? That, I might have rebound. So I think of Paxlovid as really important for people that are very high risk for being admitted to the hospital with COVID. So if I had heart failure and poorly controlled diabetes, and I was 75 years old and 300 pounds, and I got COVID, I would take Paxlovid for sure. If Mr. Crittenden got COVID, it'd be like, if you want to, you probably won't get hospitalized. The problem with any antibiotic or antiviral is that if you wait till you're really sick to take it, it's not going to work as well. So you're trying to figure out when the person's first diagnosed is, should this person take it? What I hear from most of my patients is it's the bad taste in the mouth is the worst part. I had one patient who's said her heart rate, she's a young, healthy woman, her heart rate started going really low, so she quit taking it. And when you do prevention, it's hard to figure out if this Paxlovid really made a difference for this individual. So we look at it from that broader perspective. What the research says is that if you're at high risk for hospitalization and severe disease, yes, you should take it. If you're not at high risk, it's kind of up to you. We've got plenty of it. The thing with the pharmacists being able to prescribe, that did come from the FDA, and I don't think we're doing it in health services. We don't need to. There's really easy availability to a provider that can prescribe it. It is tricky. There's a lot of medicines that if people are taking them, they need to stop their medicine if safe and take the Paxlovid or not take it. And then there's an adjustment to the dosage if you have liver problems or kidney problems. So you have to know those numbers. So it's not easy, you got COVID, here's your Paxlovid. You need to know quite a bit about the person before it's prescribed. And pharmacists are very well qualified to do that. Our pharmacists are, for sure.
Okay. Well, thank you very much for that really relevant information. So do you think that we're going to see increased masks, or do you recommend the increased use of masks in public?
Yes, absolutely. I mean, Lisa and I had quite a discussion about, hey, when we go up there to talk, we can take our masks off, right? And I feel safe today just because of distancing and the barriers and all of that. And so I think kind of my goal is that if any of you get COVID, you're not going to get it from me, right? Okay. That's why I want to wear the mask, because what you do is important, right? And you need you up and doing it. So I think about that just in general. If anyone in my office, if they get COVID, they're not going to get it from me. We've had masking in our public health office for a month, and but we still get people that test positive outside of work. So it's just one of those polite things to do.
Okay.
Keeping distance, hand washing. I'm tired of Zoom meetings, but it's better than having COVID.
True.
For sure.
Absolutely. Well, I appreciate your time this afternoon, and I appreciate all the work that's being done there in public health, and I appreciate the time, Chair.
Thank you. You're welcome.
And Dr. Dan, has the symptoms on this new strain been different? Because being in public education for 42 years, there's always a stomach bug. There's always something that runs through education, different times. And I know recently I've had, like, maybe an upset stomach is one of the so have these changed with this new variant?
They have. So what I'm seeing predominantly, and from what I hear from the providers, is it starts with a scratchy throat. So not really a cough, just a scratchy throat, and it might progress to a cough. And had several people whose symptoms started really mild, and they were testing every day, and they test negative, test negative, test negative. Symptoms get worse, and they test positive. Also seeing almost everyone has congestion, and which comes with a headache. Seeing more cases of people losing their sense of taste and smell, which we hadn't seen for a while, and then diarrhea. So seeing some GI symptoms going along with the new variant, not all that common, but the big one is a scratchy throat. So the advice I'm giving to people now, they say, hey, I've got the scratchy throat and I tested negative, but let's for now assume that you've got COVID and wear your mask and don't go to that family reunion this weekend and see how it develops. Yes, sir.
Thank you, Dr. Gann. Appreciate you coming and sharing with us very much. Lisa as well, thank you. George, thank you for coming today. Appreciate you sharing. I don't see any old business, no new business announcements. The next Health Committee meeting tentatively scheduled August 15th, 12:30. I might note too, I think everybody knows about intertribal this week, Wednesday, Thursday, Friday. I think most of the committee meetings are on Thursday at River Spirit, which is on Riverside at 9 o'clock. Plan on being at the Health Committee. It's always interesting to listen in on what the other tribes are doing in health. So just thought I'd make that announcement. Any other announcements? Okay. I would entertain a motion to adjourn. Adjourn.